All right. Well, thank you all. I appreciate you being present for the afternoon. I know these days can be quite long. My name is Shilpa Gajarawala, and I am part of the EDS clinic at Mayo Clinic with Dr. Dacre Knight and our colleagues there. So I am new to the EDS world as a provider. However, I'm not new to the world of hypermobility or the pain that we feel or the fatigue that comes with it. So thank you, Dr. Cohen, for setting me up quite nicely for my talk. Today, I'm going to talk about non-opioid pain management for EDS and HSD. I have no financial disclosures. However, I have a couple personal disclosures. I have a fear of all things creepy crawly, specifically snakes, but my bigger fear is that of public speaking. So you will see me gripping this with white knuckle death grip. So. No, thank you. My second personal disclosure is that I have EDS brain, MCAS brain, and now menopause brain. So that has left me with absolutely zero memory, so I'm about to break every rule for PowerPoint presentation, and you'll see that my slides are very dense as far as information. So my hope is that if I forget to talk about it, you can read about it later. So forgive me that transgression. So, pain. Pain had one purpose in our life. It was to protect us. It was to be our friend, as Dr. Cohen pointed out. Evolutionary-wise, it is supposed to protect us, stop us from doing things that harm us. Eventually, though, what happens? It becomes chronic, and it becomes the disease itself, and it goes from friend to foe. So, what are our goals? Our goals should be to improve quality of life, and how do we manage that? By managing pain. We do know that there's no cure for hypermobility and all of its symptoms, specifically the pain that comes along with the hypermobility, the joint dislocations, the subluxations, the inflammation, but we can kind of attack it one wicket at a time. So we want to improve functional capacity through symptom control because cure is not possible. Now, how do we go about that? You have to know what you have, the quality, the quantity of pain, by keeping a journal, by tracking, by finding out what your trigger points are. If you don't know what your pain is, what type of pain you have, you won't know what's causing it, and you won't be able to address it properly. For example, neuropathic pain, a result of nerve trauma, nerve stretching, nerve compression. Nociceptive pain, that is pain related to tissue trauma. And then we have nociplastic pain, which Dr. Cohen also touched upon. Classic example would be centralized sensitized pain, or the stigmatized name, fibromyalgia. Also, what's essential, and I'll probably keep repeating it through the whole talk, is that we have to approach everything with an individualized and a multidisciplinary approach. What does this mean? Look to your left, look to your right. No single individual or zebra in this room has the same stripes or symptoms. We all manifest it in our own separate ways, and so there is no one pill that's going to solve our problems or one approach. So we have to look at it from many different angles. Now, a little personal thing in here. My husband says I have a sense of humor that pretty much parallels Wednesday from the Addams Family. I don't think so, so he challenged me to put some humor into my talk. So the main theme of my talk is PMS. So, of course, this is not what I'm actually referring to, but I'm referring to men's PIMS, which is a wonderful acronym recently developed by Victoria Daler and Dr. Bluestein and colleagues in their recent two-part article on the integrative approach to treatment of symptomatic hypermobility. It's an excellent set of articles, and I would highly recommend you read them. But how do you approach the pain? Well, movement, education. We have nutrition, sleep, psychosocial aspects we can attack, different modalities, medications and supplements. And my talk actually is going to focus more on the medications and supplements that we can utilize. So, 2 buckets. We have non-pharmacological interventions, and then we have pharmacological interventions. I'm not going to go through all these, but what I want to stress here is that you're not just going to pick one item from a bucket or one intervention. You can pick multiple interventions from each bucket and figure out what works for you. And if you pick, say, physical therapy didn't work for me 5 years ago, it doesn't mean that it's not going to work now. So give things a second chance, third chance, or fourth chance. You never know when it might work. This is I'm sharing a little bit of unpublished data from our fabulous research group that has also accompanied us here today. The most commonly reported EDS therapies, and as you can see, it's pretty much what we preach to our patients. What's going to help you? Physical therapy and occupational therapy. And it's not just one-time hits. It's going to be something that you're going to take along with you through your lifetime. So medication-wise, as you can see, 70 to 92% of our respondents in our survey were using non-steroidal anti-inflammatory drugs, Tylenol or acetaminophen, opioids, and physical therapy. So that's a nice little group of interventions. Now, I'm not going to go through this slide because I think Dr. Cohen just did a magnificent job explaining the good, the bad, and the ugly of opioids. But they can be good, they can be bad, and we do know the risks, correct? Dependency, withdrawal, and tolerance. So, not to mention the side effects. So, again, kind of the theme of this conference is difficult conversations. So, how many of you have had difficult conversations with your providers about pain medications or felt kind of awkward bringing it up? Show of hands, perhaps. I've been there. So, just a quick example. As a provider, I've had issues as far as prescribing pain medication. For 20 years, I was in a surgical practice, and patient had a DNC hysteroscopy, and I was asked to prescribe 30 Percocet. Now, back then, 20 years ago, 30 Percocet for a DNC hysteroscopy was nothing. We did it, we didn't blink. Now, we prescribe 0 narcotics to anybody with a DNC hysteroscopy. It's not indicated. Now, I had a patient who'd had a Whipple and only took Tylenol for 6 of the 7 days that he was in the hospital. That's pretty unheard of. Now, when I went time for discharging him home, I'm thinking, all he's really taken is Tylenol. Do I really need to send him home with an opioid? I mean, the answer is no, I don't. But the surgeon, his bias, his experience kind of, yelled at me actually and said I was an idiot because I was sending a Whipple home on Tylenol. Now, what I'm trying to get at is that we all have our bias, we all have our experience, and that plays a role in what our preference is. We need to keep open minds, and kind of keep the conversation open between patient, provider, because, like I said, there's not one miracle pill that's going to help us. So the other thing is that our bias that comes in is not just from our education, but it's also drug companies, it's advertising, it's what we are constantly, I could say pushed in our face through TV, radio, internet, etc. That does guide our choice in drugs. I know our campus about 15 years ago went completely sample-free because they said that samples were biasing our choice. So hand in hand, I think the same thing also applies to opioids. So what we're going to kind of go over briefly, keeping time in check, is non-opioid options. Some of these, actually most of these you're probably familiar with, and forgive me that I'm kind of doing a generalized overview. First one, Tylenol, which acts on the central nervous system. It's good for fever, it's good for pain, but guess what? It's not so good for inflammation, so keep that in mind. So it's good for nociceptive pain, has relatively low gastrointestinal side effects, but high doses, and if you're drinking alcohol, it can have some pretty bad, nasty effects on your liver, so be aware. And of course, it's over the counter and fairly cost-effective. Non-steroidal anti-inflammatories, NSAIDs, also known as the ibuprofen medications. work through the COX enzymes. They reduce prostaglandin, which plays a very big role in inflammation and pain. So it is suitable for nociceptive pain that is associated with inflammation. So if you're having inflammatory pain, is the Tylenol going to work better, or is an NSAID going to work better if you can tolerate it? How many say Tylenol? Good, okay, you're listening. Now remember, NSAIDs have a possibility of GI irritation, can cause issues with blood pressure. If you've had a previous heart attack, also be careful with use. And it can cause some kidney dysfunction with long-term and high-dose use. Now, forgive me, off-label discussion of anticonvulsants, things like gabapentin, pregabalin, which were initially developed for seizures. So they modulate calcium channels, and real simplified, they reduce transmission of pain signals to the central nervous system. So really, really good medication for neuropathic pain and chronic musculoskeletal pain. But again, they are not without significant side effects. So sedation, dizziness, weight gain, which is a big side effect in my world, and the potential for physical dependence, which means that discontinuing a medication like that may be not so easy. So, and of course, insurance coverage is pretty good. Now, antidepressants, I think this is what I call, two birds with one stone. Mood medications obviously help with depression and anxiety, which are common comorbidities with EDS and HSD, but they also help with pain. The neurotransmitters, serotonin, norepi, they have their own pathways that can kind of do their magic as far as helping with pain, sleep, and mood. So, which antidepressants? We have the SNRIs, such as duloxetine and venlafaxine, which help with serotonin and norepinephrine levels. It's good for neuropathic pain and nociplastic pain. Now, the nociplastic pain, if you remember, is the fibromyalgia type of pain. Side effects, of course, nausea, dizziness, withdrawal symptoms, and of course, with any sort of antidepressant, I believe sexual side effects or dysfunction. That's just one more layer that you don't need on top of everything else that we are dealing with. The SSRIs, a bit probably more commonly known, like Prozac and Zoloft. So they work by serotonin levels. So they are more effective with the nociplastic pain, not so much the neuropathic pain. And of course, they help with depression and anxiety. Again, like any other mood medication, GI upset, and sexual dysfunction are kind of the main cons. Coverage is pretty good through insurance, because they've been around for quite a bit. And I'll admit, my experience with tricyclic antidepressants is pretty slim. So if you have questions about it, please don't send them in. So amitriptyline, nortriptyline, they are very good for neuropathic pain, but the side effects of the TCAs scare me, I think, especially long-term use. So they do help with sleep. They have definitely, Dr. Cohen, the good, the bad, the ugly, but it's just something that I've kind of shied away from. I would probably not have this at the top of my list of things that I prescribe, so. Muscle relaxers, kind of mixed feelings on these. I think good for acute situations, definitely cause more trauma than help in long-term situations. If I could do a little survey again, how many of you take a muscle relaxer daily? How many of you don't take a muscle relaxer daily? Okay, you guys are still listening. All right. So, remember, our muscles are already kind of not cooperating. They're not sleepy, they're weak, they're not supporting us like they should. Think about it, is a muscle relaxer really a good idea? Acute situation, I'd say yes, but on a daily basis, definitely no. We're already compromised. The popular kids on the block, yes? I bet if I did a survey now, I'd see a lot of hands going up. Okay, well, you spoke up. Which is your preference? The CBD or the THC?
Primarily Delta 8.
And what?
In Missouri, you can get a medical card. So.
Yeah, medical cards are good. So for those of you who aren't familiar, CBD, right, has the non-psychoactive component.
I prefer CBG.
CBG?
Yeah.
You might have to come up here and talk about that one.
I don't know how to explain it.
Or medical marijuana, which has the THC, or the active component, which probably is the one that gives you the munchies. Not that I have any personal experience with that. So side effects, of course, euphoria, dizziness, munchies, drowsiness. You have to be careful with the CBD products because sometimes they're not quite as regulated and there's variability in quality that you're receiving. And of course, medical marijuana in itself has the potential for dependency. So, but again, you have to weigh the benefit versus the risk. I don't think a gummy bear here or there ever hurt anybody. So, all right, topical medications. This is the first day of my trip that I do not have lidocaine on my shoulder and my hip today, so it's a good day. So you get patches, creams, gels, and I think even some sprays out there. I'm just curious, I know I kind of tend towards the topical lidocaine patches, so again, I love little informal surveys. How many of you use topical NSAID type creams? Okay, I think you're gonna put your hand up for everything. How about lidocaine? No? I got a few. Zinc topical.
No, zinc.
Zinc?
Yeah.
I'm getting to that. Yeah. How about a little hot pepper, capsaicin cream? Yeah. A little tiger balm, right? So, and then menthol or camphor, which is kind of a distractive agent. So anybody here? It's kind of a bit old-fashioned. Oh, thank you, Dr. Cohen. All right, got one. All right, so really good for localized discomfort and pain. You can probably use them chronic, long-term, but you have to be very careful because we're already fragile. Our tissues are fragile, and you want to make sure you're not burning yourself or causing any other sensitivities. Trigger point therapy, kind of like, you know, in between the pharmacologic versus non-pharmacologic, but I thought it was worth mentioning. Spasms, I get them all the time in my neck. Occasionally I get some dry needling done. Never had a trigger point, at least I haven't in the last 10 years. But you can use, what do you use? You can use corticosteroid, you can use lidocaine. Not much more to say, but again, you have to be careful because we are prone to bruising and bleeding. So make sure you go to somebody who's excellent at this type of therapy and experienced. A little bit more unpublished data. So in our EDS and HSD population, it looks like NSAIDs take the lead and then Tylenol, followed by kind of a close run, I'd say, with muscle relaxers and CBD derivatives. And I am happy to see that the opioids are not in the lead on anything. So here we go, zinc time.
Yeah. I've been taking zinc on a zinc trial. I have no pain. I've got off all my medications. My blood has returned to normal. My ESR, CRP is all normal in the last 10 months. My B12 and my folate have went to normal ranges due to how zinc processes the homeostasis of that. And I haven't looked back. I don't have any pain currently. I've had multiple surgeries. I think it's fantastic, and I've changed my diet. And my inflammatory response has stopped.
I think you need to stand up. We need stories of success because it gives us hope. So, how much are you taking?
I can't say currently because I'm on a trial. Currently.
Keeping secrets, are you? Okay. All right.
I've also done less hypermobile. I've lost 48% hypermobility in 10 months.
Oh.
And my DECA in my eyes changing with blue sclera. It's getting lighter.
Oh, you got to speak up.
I know. I've been told, don't worry. I'll stop now.
All right, so supplements. Thank you for that awesome story of success. Unfortunately, she's in a study, so she can't tell us more. Zinc supplement. She's had fantastic results with it. I'm sorry. Basically, she's symptom-free at this point. Would that be a good summary?
I think I would say for them to go to their medical professional. There's multiple publications in PubMed and Elsevier for them to read if they need a further reference for it, because there's multiple contributing factors, because certain medications can bleed zinc such as contraceptive pill, PPIs and so forth. So it's very important they go to a medical advisor.
All right. Well, I'm hoping I included zinc on my next slide. All right, so we know data is lacking. It's not all quite there. Hopefully the study you're in was going to be, groundbreaking. But we extrapolate from how supplements help with, with other painful conditions. Now, I'm not saying I'm pro-supplement or against supplements. I think they're worth a try as long as there's no harm. And you are mindful of your other medications and interactions. So, big list here. Let you read through it. I'm not going to go one by one. Hold on. Did I put zinc in here? Live and learn, live and learn. Okay, I'll be correcting that. But what I want to point out, what is a common theme that you see in all the supplements? Gotcha. Inflammation, anti-inflammatory properties. So think about that. Anything you can do to decrease your inflammation is going to be beneficial. I'm going to run out of time, so I'm going to kind of click through here. Again, some little bit of data to share with you. Just wanted you to see that the most benefit, physical therapy, medical marijuana, and I also wanted to point out, because I have a lot of patients who come in who see chiropractors, and that kind of scares me a little bit. I don't think it's wrong, but I think any sort of aggressive manipulation needs to be probably avoided, so. Pharmacogenomics. Dr. Cohen mentioned that briefly. I think it is like, come on, share.
I had pharmacogenomics done through Genome Medical, primarily because I've had a lot of trouble with, especially antipsychotics for my autism, because I get really, really bad and extrapyramidal side effects. And I feel there may be something that could cause me to be more prone to it. And I have found that I have like a few different mutations on MTHFR and a few other genes in my pharmacogenomics. And they're really interesting.
No, I think it's something that we should be looking into a lot more as far as tailoring treatment based on genetics. So I had a case report, but let me just read through it real quick. 32-year-old patient with history of recurrent dislocations, chronic pain, and skin hyperextensibility. Family history, mom and sister with similar symptoms. Physical exam, generalized joint hypermobility, skin lacks hyperextensible skin, visibly lax skin. Basically, she has hypermobility EDS, but she also has a history of adverse drug reactions and varying responses to treatments. So she had the pharmacogenomics treatment done, and let me just real brief, CYP2D6 metabolism of CNS drugs gets affected, antidepressants, antipsychotics, and opioids. So she had a deficiency in that, and therefore opioids, wouldn't matter what I gave her at this point, super simplified, it wasn't going to help her. So eventually opioid meds were taken off the table, and she was started on a combination of non-opioid analgesics and did quite well. So again, due to time, I'm going to keep going through. Patient-provider education. I don't think I need to go through this slide because case in point, I didn't put zinc on here. So I'm learning. So yes, patient and provider, we all have room for education and learning, and I am thrilled to be at a conference where there is provider presence and patient presence because I'm learning a ton. So 3 essential facets of EDS pain management. You have to take care of the physical symptoms. You have to look at your daily limitations or how it's affecting your life, not just your occupation. And of course, your psychosocial factors. So physical symptoms, look at the physical therapy, the medications, any assistive devices. Occupational factors. Is my laptop or my desktop at the right height? Is my chair appropriate for me? Is it supporting me or hurting me? And of course, meditation, support groups, whatever it takes, don't be afraid to reach out and try it. It takes a village, right? It's not just going to be you alone. It's not going to be the provider dictating. It's going to be a joint effort in 47 seconds of collaboration, cooperation, communication, and comprehensive care. So keep going. Conclusion in 38 seconds. Make sure you do look at non-opioid medications, and it may not just be one. If Tylenol gives you 10% relief, an NSAID gives you 20% relief. Together, that's 30% relief. So that's a win. Look at supplements, including zinc. And always be open to learning. And remember, it's a multidisciplinary, multimodal approach. So again, I'm sorry I'm rushing through the last few slides, but I appreciate your attention and your cooperation, in the mini surveys. So thank you.